All right, so I'm Dr. Wolfe. I'm a pathologist, and in pathology, we are experts in diagnosing disease. And today I'm going to talk about Graves' disease, okay? And this is a disease of the thyroid, and I am actually going to be reading from the basic medical textbook that medical students all across the United States and the world study from, and it is called Robbins' Pathologic Basis of Disease. It's really the best book you can have to learn kind of the basis of every major diagnosis. And so what I'm going to do is I'm not going to read the entire section in this one video. I'm going to break it up over a few videos, okay? Probably something like 3, depending on how it goes. But basically what I'm going to do is I'm going to read the text of this, and then I'm going to explain as we go what it means. So this is, medical students can watch this and they don't have to read the book themselves, or people who are interested in thyroid disease, Graves' disease, or anybody who's just interested to hear the interpretations from the pathologist's perspective. So on the 8th edition of Robbins, page 1114, that is where Graves' disease is. So Dr. Graves reported in 1835 his observations of a disease characterized by, quote, violent and long continued palpitations in females, end quote, associated with an enlargement of the thyroid gland. So what that means is, by violent, presumably meaning powerful contractions of the heart, palpitations, fluttering of the heart, mostly in females, with, on physical examination, an enlargement of the thyroid. So the thyroid is a butterfly-shaped gland on the front of the neck, just above what we call the sternal notch there. If you look where I'm putting my fingers, my thyroid is there. Some people can feel their thyroid. Certainly if it's enlarged, you can feel it. But when I put my hand up to my neck there, I don't feel anything in particular that says thyroid. So it's good. It's a good thing to do for anybody to kind of feel that area and become familiar, because if you were to find a change like a nodule, that is important to tell your physician. So Graves' disease is the most common cause of endogenous hyperthyroidism. And so endogenous meaning from within the body, from within the thyroid, hyperthyroidism, okay, so overactive thyroid. It is characterized by a triad of clinical findings. And a triad is a term we use in medicine, meaning 3 things. Number 1, hyperthyroidism due to diffuse hyperfunctional enlargement of the thyroid. So this basically means diffuse, meaning throughout the entire thyroid, not a part of the thyroid, not a nodule within the thyroid, but diffusely, meaning throughout. Hyperfunctional, so too much thyroid hormone being produced. And enlargement, of course, like we talked about before, being able to feel or see the thyroid. Number 2, an infiltrative ophthalmopathy, which basically means a pathologic condition of the eye, with resultant exophthalmos, okay? So let me explain what that means. With Graves' disease, and we'll get to the infiltrative part, meaning it's within the soft tissues around the eye. And what happens is you get an increase of material there, which pushes the eyes forward. And that's what is meant by exophthalmos. Ex meaning out of, and thalmos meaning eye. So your eyes are actually bulging out. And so some people have naturally bulging eyes, but in this case, what we're talking about is an eye that is clearly protruding to the point that when the eyes are open, the lids typically aren't touching the iris, or what appears to touch the iris. So if you look at my eyes, you can see my lids cover the bottom and the top of the colored part of my eye. But in exophthalmos, you would see the white of the eye instead. Number 3, localized infiltrative dermopathy, sometimes called pretibial myxedema, which is present in a minority of patients. So an infiltrative dermopathy, meaning a pathologic condition of the skin, pretibial myxedema. So pretibial meaning that's on the lower part of the leg. So you can see the root there, tibia, pretibial meaning in front of the tibia. And it says present in a minority of patients. So people can have Graves' disease and not have this condition. Graves' disease has a peak incidence between 20 and 40 years of age. Women are affected as much as 10 times more frequently than men, but men can get Graves' disease. This disorder is said to be present in 1.5% to 2% of women in the United States. So in other words, 1 to 2 out of 100 women are going to have Graves' disease. As previously mentioned, Graves' disease and Hashimoto thyroiditis, which is a type of hypo or underactive thyroid, hypothyroidism, span two extremes of autoimmune thyroid disorders, and not surprisingly share many underlying tenets. For example, akin to Hashimoto thyroiditis, genetic factors are also important in the etiology or cause of Graves' disease, with a concordance rate in monozygotic twins of 30 to 40%, as compared with less than 5% among dizygotic individuals. So monozygotic twins means that a set of twins that have the exact same DNA because they split from the same egg. And so with dizygotic, that means when a woman has ovulated two eggs and there's a twin pregnancy with two separate eggs as opposed to splitting after the fertilization. And so it's basically saying that in the case where the DNA is the same, there's a much higher rate of development of Graves' disease. In one individual who gets Graves' disease, the other is 30 to 40%, as likely to get it. Like Hashimoto thyroiditis, genetic susceptibility for Graves' disease has been linked to polymorphisms in immune function genes like CTLA4, PTPN22, and HLA-DR3 allele. Now, that is information that for the general public, for anybody watching this who's interested in Graves' disease, that is not particularly useful to you. That could be for a medical student, that could definitely be a question on your board exam or in your pathology class, endocrinology section. They could talk about that. I'm not going to go into the specifics on those genes there. I just feel like that's a little beyond the scope of what we need to get into. All right, so the next section is pathogenesis, which means how does the disease condition arise? Graves' disease is characterized by a breakdown in self-tolerance to thyroid autoantigens, most importantly, the TSH receptor. So let's break that down. What that means is our body, so the thyroid cells have receptors which bind thyroid stimulating hormone. That's what TSH is. And most of the time, we don't have any problem with it, but it's saying that at some point, the body stops tolerating the self-tolerance to thyroid autoantigens to that TSH receptor. So something that should not be happening is now happening to the TSH receptor with those autoantibodies. The result is the production of multiple autoantibodies, including first, thyroid stimulating immunoglobulin. So an immunoglobulin is an antibody. This IgG antibody binds to the TSH receptor and mimics the action of TSH. So in other words, for your thyroid to function properly, thyroid stimulating hormone is released from your pituitary gland in your head, and it goes throughout your bloodstream. It finds its way to the thyroid, and those little thyroid cells have receptors, and the TSH binds onto the TSH receptor and it activates it. So then your thyroid produces thyroid hormone. So in this case, there is an antibody that binds to the TSH receptor instead of TSH. So you're going to get activation of those cells. And this stimulates adenyl cyclase and increasing the release of thyroid hormones. So you don't have to worry about those enzymes. I mean, if you're a medical student, of course, you need to know that. But what it's saying is it's activating the release of thyroid hormone. So you can see how the increase in thyroid hormone is going to occur in this. Almost all individuals with Graves' disease have detectable levels of this autoantibody. With thyroid stimulating immunoglobulin is relatively specific for Graves' disease in contrast to thyroglobulin and thyroid peroxidase antibodies. In other words, if you go to your doctor with symptoms of Graves' disease, the doctor may order this particular immunoglobulin that stimulates the TSH receptor. So that's something your doctor is going to look for to help you understand if you truly have a Graves' disease. Next is thyroid growth stimulating immunoglobulin. This is also directed against the TSH receptor. Thyroid growth stimulating immunoglobulin have been implicated in the proliferation of thyroid follicular epithelium. So the thyroid is a gland composed of follicles, that's what they're called, and they're little glands that are filled with what's called thyroglobulin. And it's saying, once again, we have an antibody that is attaching to TSH receptor and causing activation. Next, TSH binding inhibitor immunoglobulin. These anti-TSH receptor antibodies prevent TSH from binding normally to its receptor on thyroid epithelial cells. So in this case, the antibody's binding the receptor on the cell surface, and it's not letting TSH as normal come in, okay? In doing so, some forms of TSH binding inhibitor immunoglobulins mimic the action of TSH, resulting in the stimulation of thyroid epithelial cell activity, whereas other forms may actually inhibit thyroid cell function. It is not unusual to find the coexistence of stimulating and inhibiting immunoglobulins in the serum of the same patient, a finding that could explain why some Graves' disease have episodes of hypothyroidism. So to break that down, what we're saying here is that we have the thyroid stimulating hormone receptor, and in some cases, the antibodies come in and activate it, and in other cases, they come in and they block it. So they're saying that some folks with Graves' disease, even though it is a hyperthyroidism, can have episodes of hypothyroidism. And so this is problematic because the symptoms for hyperthyroidisms can also be very uncomfortable, but so can hypo. So these folks are not feeling good. Let's continue. The key role of anti-TSH receptor antibodies in the pathogenesis of hyperthyroidism is supported by animal models of Graves' disease. Immunization of mice with the TSH receptor results in generation of antibodies that cause thyroid stimulation, thyroid enlargement with lymphocytic infiltration, elevated thyroxine levels, and in a subset of mice, ocular signs reminiscent of Graves' ophthalmopathy. So what does that mean? That means they have taken mice and they have injected mice with purified TSH receptor, so an antibody. The mouse's immune system has produced antibodies to that protein, which then act on the mouse's thyroid to produce symptoms of Graves' disease. So they're basically saying they've proven that this autoantibody has that effect in an animal model. Next, autoimmunity also plays a role in the development of infiltrative ophthalmopathy, that is characteristic of Graves' disease. In Graves' ophthalmopathy, which is, once again, that is a strange word you've probably never heard, but meaning a pathologic condition of the eye, the volume of the retroorbital connective tissues and extraocular muscles is increased for several reasons. Retroorbital meaning behind the eye. Number one, marked infiltration of the retroorbital space by mononuclear cells, predominantly T cells. So what does that mean? A T cell, a mononuclear cell, a T cell, is a type of lymphocyte, which is part of your immune system. So there are immune cells there that shouldn't be there. Number 2, inflammatory edema and swelling of extraocular muscles. So our eyes, the way that we're able to move our eyes left and right and up and down, that is from the extraocular muscles. And those are the muscles that are they actually attach to the outside of the eyes, behind the eyelids. I mean, you can't see those muscles, but that's what they're talking about. The inflammation is there, and with inflammation, very commonly, our body will bring in fluid, and that's what causes the edema. So you've got the increased T cells, and you've got the swelling of those muscles. Number 3, accumulation of extracellular matrix components, specifically hydrophilic glycosaminoglycans, such as hyaluronic acid and chondroitin sulfate. So basically what that's saying is there's material outside of the cells that's aggregating. So extracellular matrix, meaning outside of the cells. And this is a type of a glycosaminoglycan, okay? So this is something that if you're in the general public watching this, you're not going to need to know really what that means. Medical students, for sure, you're going to need to know that for your boards, and specifically the hyaluronic acid and chondroitin sulfate, okay? And then number 4, increased numbers of adipocytes, also known as fatty infiltration. Adipocyte or adipocyte is a fat cell, so you get increased fat. And these changes displace the eyeball forward and can interfere with the function of the extraocular muscles. Recent evidence suggests that orbital pre-adipocyte fibroblasts express the TSH receptor and thus become targets of an autoimmune attack. In other words, what it's saying is the cells around the eye there, they, just like your thyroid can respond to those autoantibodies, they can respond to those autoantibodies, and that's why you produce problems with the eyes. T cells reactive against these fibroblasts secrete cytokines, which stimulate fibroblast proliferation and synthesis of extracellular matrix proteins, the glycosaminoglycans we talked about, and increase surface TSH receptor expression, perpetuating the autoimmune response. In other words, it's saying that fibroblasts, which is a type of connective tissue cell that produces collagen typically, they are secreting a protein called cytokines, and which causes the cells to increase in number. That's what they mean by proliferation. And then those cells produce that extracellular matrix that causes the eyes to project forward. And it also increases the TSH receptor expression on the surface, meaning all those cells back there behind the eyes also are increasing the amount of TSH receptor. So those anti-TSH antibodies that are affecting your thyroid are affecting your eyes worse and the material around your eyes. The resultant is progressive infiltration of the retroorbital space and ophthalmopathy. In other words, what they're saying is all of that stuff we just talked about is explaining why the eyes have the changes with a thyroid. It's not intuitive that an autoimmune disease of the thyroid would have problems with the eyes, but it's because they can express those TSH receptors. Now, I think that's enough for the first video. We will be able to do Graves' disease in 2 videos. In the next video, we're going to talk about morphology, which means what does it look like? So what does it look like grossly, i.e. without a microscope, and what does it look like under the microscope? And secondly, we will also talk about clinical course. So that would be like the symptomatic stuff, okay? So this is just a little experiment I'm doing, reading some sections out of Robbins, helping the general public, and maybe somebody who's in medical school or nursing school and wants to know a little more about Graves' disease. It's kind of like having somebody read it to you and explain it to you. All right, thank you.